Well, good. So I want to, with all of our discussions tonight, I think understanding the problem is really it's going to be important to understand the anatomy. And so I wanted to just start with Achilles tendonitis because it's one of the most common conditions, and it affects almost everybody at some point in their life, depending on your activities. The Achilles tendon we always think of the Achilles tendon as the lower portion that joins on the heel, but the Achilles tendon is really made up of not only the Achilles tendon, but it is the soleus muscle, which is in the lower leg, the gastrocnemius muscle, which has two heads, and that's what we think of as our calf muscle. But it actually involves the muscles above the knees as well. The hamstring starts up above the hip and comes below the knee, and we can see the insertion here. And so I try to think of this as the functional chain. And the functional chain is funny because when you're hurting in your Achilles or the back of your heel or the bottom of your heel, you think the problem is there. But the problem is really related to the forces that your heel is seeing from the muscles up above in your leg. And so much of what we talk about in foot and ankle affects other things in your body. So when you're having foot pain, or you're walking differently, or trying to offload your foot in certain ways, and so walking perhaps funny, it can throw off your hip and knees and lead to other problems like trochanteric bursitis or hip pain or knee problems. And so I think that having a background that is not just a foot and ankle background, but really understanding the lower extremity and how things work together is really important. The reason I want to start with anatomy is because the Achilles tendon tends to have two areas that are distinct and separate that suffer in Achilles tendon issues. One is the one that you can see on this slide, and it's in the central portion of Achilles just above the calcaneus. And that's probably the most common place that we see Achilles tendon pain. The other area is down where the Achilles inserts on the bottom of the heel. And I call this insertional Achilles tendonitis versus Achilles tendonitis that is more in the central portion of the tendon. And although the pain may be located in different areas, the reason for the pain is really the same, which is overload or repetitive pull on the Achilles from the muscles above. Achilles tendonitis is also affected by the foot below. And I think that tonight it's a good time to just back up and say the foot is an amazing structure. There are 26 bones, and they all work together to allow your foot to be a shock absorber, to be a lever to push off of. And then there are a tremendous amount of nerves and tendons that help with sensation and proprioception, which is a big doctor word for knowing where your foot and body is in space. And so all of these structures work together and function together. And we're going to talk tonight about several different conditions that may have similar type of presentations. So try and give you a little background there. I wanted to talk about Achilles tendonitis, which is classically inflammation in the central portion of the Achilles above the back of the heel. And this is probably the most common place where people start to have pain and sometimes even develop a lump in the heel. You can see that picture on the right with the little bracket around it where it says Achilles tendon. And what you can see is there's swelling. There's actually a palpable mass or some thickening of the Achilles. In a setting of no acute injury, sometimes you can have a little strain or just overuse, and you'll have some short-term swelling. And that may get better with time as your body is responding to the tendonitis and you're stretching and doing things to make it better. There's also something called Achilles tendinosis. And tendinosis, itis means acute inflammation, so Achilles tendonitis is an acute problem. And tendinosis means that the tendon is starting to degenerate or to change. And that's after a kind of a more chronic situation. And in an Achilles tendinosis situation, if the lump has been there for a long time, say years, it probably will never go away, the lump itself. But that doesn't mean that the symptoms won't go away. And so I think it's important to know that the lump is a sign, but it doesn't mean that it needs to be addressed necessarily surgically, or that you're going to have pain forever. It's just a sign of where the problem is. The Achilles tendon in this area also has some specific or peculiar findings here, and it has to do with blood supply. I described the Achilles tendon as having a really good blood supply above where the muscles are, where the gastroc and soleus in that previous picture. Up in here, there's a very healthy blood supply. Down at the bottom of the heel, there's also a healthy blood supply, but in this pink zone, that's what we call the watershed area. And I describe it like two sprinklers that aren't quite overlapping on a hot summer day. You can imagine that the lawn that isn't quite getting the water dries out or isn't quite as healthy as the rest of the lawn. And so this area, about 3 to 4 centimeters above the heel, the watershed zone, is really the classic area of Achilles tendon injury and tendonitis. And it has partially to do with just the blood supply to the tendon. The presentation of Achilles tendonitis varies. Sometimes it can be a dull ache, and as you're active or hiking, you feel it a day or two afterwards as you're getting up in the morning, and pain and stiffness in the back of the heel. Sometimes Achilles tendonitis starts as an overuse injury where you're out exercising and you actually have pain in the moment. You feel like, oh, I just strained my Achilles or something happened, and it can start as just a little mild twinge and then become more of a chronic problem where after a few days or a few weeks you're still having problems, and that problem actually is getting maybe worse instead of better. And so I want to give you some ideas of when is it serious and when is it not. And then I also want to talk about Achilles tendon rupture. And Achilles tendon rupture is when the tendon actually fails. And so in this picture, you can see that the Achilles is still attached to the calcaneus. There is a rupture in the area of the watershed zone, and that's almost always where it happens. And then almost like a window shade that's rolled up, the tendon retracts back up into the leg. And this is an injury that I would love to help every listener avoid. This is what we're going to be talking about prevention-wise. And so I think that's one of the questions I hear almost every visit when somebody has Achilles tendonitis is, what's my risk of rupture? Is this going to go on and tear, and am I going to need surgery? And the good news is that Achilles tendonitis rarely goes on to rupture, but it can. And so I think that there are things that in treating your pain that you can do that help prevent a rupture. I also want to just talk about rupture as a separate entity before we go back and talk about tendonitis, because ruptures can happen in young athletes, and they can happen in, I think more classically, we think of the weekend warrior, guys like me who used to be very active and maybe are working a little more than we should be and not exercising regularly. And then it's a beautiful day and you've got an opportunity to go out and play pickleball or do something, and your energy and enthusiasm is there, but your tendon is not ready. And that's one of the things that just being active and prepared for the sports that you're doing is probably the best thing you can do to prevent rupture. The reason that it happens in weekend warriors is because tendon, just like bone, responds to the forces it sees all the time. And so my son is 15, he's a basketball player, and he is working out every day, several times a day. I wish that I had the time to spend more time working out with him, but his tendons are seeing a load every day and they're responding to it. So when he goes to play basketball or jump or try to dunk, his tendon has been seeing those forces and is ready to handle it. It's strong. When somebody that has not been exercising regularly and then goes and puts a very high load on that tendon, it's almost, the tendon just isn't been used to seeing it. And so that's the patient or the person that is more prone to a rupture. So things that I tell patients to reduce the risk of rupture are to actually vary your activity and to be as active as you can be, kind of without having symptoms. And so that usually means what I think of as common sense, which is starting with slower, shorter duration, less intensity, and really just listening to your body. And if you're doing great on a 20-minute walk or 20-minute hike, and you're able to do that for a few days or a week in a row, then it's prudent to kind of progress up both with your time and intensity. But it's really, if you haven't been running, for example, I think that we all remember if you're a runner, most people have a distance that they start with, and I think, or a time that they start with, and they say, oh, I can run 2 miles or 2.5 miles or 20 minutes. And maybe when you were running frequently or intermittently, that was a good place to start. But as our bodies change in age, or we've been less active for a period of time, you can't always start where you did 10 years ago. Or I know when I was in college and I would take a break from running, I would always kind of start at 3 miles. And I imagine if I tried to go out and run 3 miles now without having done it in a while, that my body and feet would really hurt. So work up slowly, and you could avoid a lot of these problems, and certainly, hopefully, never be where we are in this slide. I wanted to go back and talk and show you an X-ray of the back of the heel. This is a calcaneus. The calcaneus has the Achilles tendon. Let's go back 2 slides, actually. Oh, sorry, I'm going the wrong way. Sorry, I'm not finding the slide I am looking for. This is the slide I wanted to show you. So if you look at the slide on the left side, you'll see just the bony structure of the foot, with the calcaneus being the heel bone. And you can see the Achilles tendon coming down and inserting on the back, and the plantar fascia originating off the bottom of the heel and coming across the arch of the foot. And I think that most of us think of plantar fasciitis and Achilles tendonitis as separate pains, separate problems, but the underlying problem is really the same. And I describe it as a tug of war on the heel between the Achilles tendon on the backside and the plantar fascia on the bottom. And that tug of war is affected by things like the tightness of the muscles in your hamstring and calf muscles, and also by your foot structure below. If there's a flat foot and the arch is collapsing, it puts extra pull on the plantar fascia and can actually make it more likely that plantar fasciitis or Achilles tendonitis happen. So when you are being treated for this, or seeing a physical therapist or a physician, or even a salesperson, a knowledgeable salesperson at FootZone, they'll be looking at your foot and the way that it hits the floor, looking for deformity, and really analyzing things that maybe as a patient you don't see, even if you're looking every day. So I like to talk about, with Achilles tendonitis and plantar fasciitis, things that you can do to reduce the force or to limit that tug of war that's happening on the back of the heel. Sorry, my slides were changed around today. I wanted to show you a slide that talks about some prevention strategies for Achilles tendonitis. There we go. No. Perfect. So with Achilles tendonitis, the cornerstone of treatment is really breaking the cycle of repetitive micro-injury and allowing your body to heal. And we talked about reducing force as one of those strategies, and the best way to do that is by stretching the muscles in the functional chain the gastroc and the soleus, or the calf muscles, but also the hamstring and the muscles in the thigh that are contributing to the force on the foot. And I will make sure that on our website we have some links to handouts for both plantar fasciitis and Achilles tendonitis that include these stretches. The stretching exercises, I tell patients that this is not something that stretching once or twice a day for a minute at a time is nowhere near as good as stretching 7 or 8 times a day for 10 or 15 seconds. And so as we sit for a period of time, or as we sleep at night, our muscles tighten up, and then you get up and stand or take the first step. And that's oftentimes when people really feel their pain from their Achilles, is that first step in the morning. Colleen, if you heard people say when they come in, when I get up in the morning, I just feel so stiff. I feel like I can hardly get moving. It takes me 5 or 6 steps to get across the bedroom, and then it kind of loosens up and gets better.
Definitely. I would say that's a very common complaint and concern with both Achilles tendon issues as well as plantar fasciitis. And I'll echo what you said about the frequency of stretching, as well as give a little more detail on that with folks that that stretch does not have to be an extreme stretch. In fact, it should be a very low grade, long hold stretch where folks frequently think more is better. And more is better if it's an appropriate amount of stretch.
I like that saying though, more is better.
Right. So that low grade, very gentle stretch without bouncing, kind of subtle hold is what we're looking for with that, frequency throughout the day, for sure.
Great. Well, what I was going to say is that I frequently see the complaint that, gosh, it gets better throughout the day, and if I do something, I go for a hike, I walk Pilot Butte, that the next morning I wake up and I'm really sore. And I want our listeners to know that that first pain of the day is your first opportunity to really make a difference and to help improve the problem and to get this to go away. And every time you're feeling pain when you take a step, whether it's in your Achilles or on the bottom of your heel for a problem like this, I describe it as blowing on the embers of the fire that you want to go out. And so in a situation, pain is not your friend with Achilles tendonitis. It is your body telling you, I'm in an injured state and that I need you to give me some rest and allow things to heal. So I tell patients that the most important stretch of the day is the one before you get out of bed. So I tell patients, if you can take 10 or 15 seconds aside and then repeat it a second time. So that works out to about a minute before. So if you normally get up at 6 o'clock, set your alarm for 5:59 and spend that 1 minute before you get out of bed and taking your first step, and just loosen up. Stretch your calf muscles, stretch behind your knee, stretch that hamstring, even pull your toes up towards your chin, and that will help to stretch the plantar fascia or the tissues at the bottom of the foot. The next kind of word of wisdom is that before you get out of bed and put your foot on the floor, having something to kind of take the force off of the Achilles. And so I recommend a house shoe or something that's easy to slip on. Many women have a shoe that doesn't have a back on it and has a little bit of a heel. I think my wife sometimes called it a mule, but something that is comfortable to slip on, easy to slip on, and that when you take that first step is going to prevent your heel from dropping all the way to the floor and put a lot of force that could actually reincite or flare up that injury again. So the stretching is by far, we're going to talk about stretching again and again tonight, but I think it's probably the cornerstone of treatment. I think that the other thing that I would say is it's in the middle of the list over here, but rest. And rest means something different to everybody. For a 26-mile runner who's doing several marathons a summer, it means something very different than to my mother who walks daily but is not competitive in her activities. And I tell patients that rest doesn't mean that you need to be a couch potato or that you need to be on your, on your back. It's choosing activities that are not going to be hard or painful for your Achilles or your foot. And so low impact exercise is a great way to still get your heart rate up, to clear your mind, but to give your Achilles and your foot a rest. And so things like stationary bike or swimming or even water aerobics, where you're not putting all of your body weight through your foot on every step. And so I think that it's a combination of, as you start to feel symptoms, backing off in your activity and trying to stay below the pain threshold. I think that rest or avoiding the activity, if it's running or walking pilot view, that seems to be causing your symptoms while they're getting better. And then also, I think simple things like an anti-inflammatory, like Aleve or ibuprofen, icing as you get home from a walk, stretching and icing just to help with acute inflammation. And then we're going to talk a little bit about shoe wear, and I'll turn it back over to Colleen. But choosing shoe wear that takes some of the force or stress off of the Achilles. And I describe those shoes as having drop or a heel lift to them. Colleen, I know you have an example of a shoe that has some drop with you, and I will maybe if I escape out of my screen, hopefully that will allow you to take over the screen. Is it working?
I think people can probably see.
Great.
So when we talk about drop with respect to a shoe, it's not the first thing that we discuss when we're fitting a client. And of course, I would tell you that no matter what I say tonight with respect to a shoe and what it could or couldn't do, what's always best, of course, is to come in and have us take a look at your feet and do a scan of your foot and watch you walk and see what's going to work best for your anatomy. Because what may fit and work well for one person and their Achilles or their plantar fascial problem may not work well for another. But with respect to drop, what we're talking about is a shoe that, when you look at it, has a difference in the heel height to the forefoot height. So this Brooks shoe here has a fair amount of drop. I believe this one is in the neighborhood of 10 to 13 millimeters. That's the difference between the heel and the forefoot. Something that has that bit of drop is going to lessen the load on your Achilles because it's elevated just a little bit, and that Achilles doesn't have to work quite so hard. In contrast, this shoe here, which is a trail shoe, but you can see it's much flatter, and there is zero drop in this shoe from the heel to the forefoot. Now, this shoe may be very good for some folks that have different foot anatomy problems, but probably not your best choice if you're dealing with an Achilles problem, a calf problem, or perhaps a plantar fascial problem because of the restriction in those structures. Yeah.
I'm glad you did a great job of explaining that. That's I think that people don't understand or maybe haven't heard a lot, but it's a term that in the shoe wear and it describes that difference between, it really means that there's a lift or a heel on the shoe. And that difference, as Colleen said, by having a heel lift, it takes some of the pull with each step off of the Achilles, and particularly where it inserts on the back of the heel. I think I hear patients ask me questions every day about, well, gosh, I'm wearing a shoe that has a heel, but I'm stretching all the time. That doesn't make sense to me. If I'm stretching, why am I wearing a heel? And I just want to tell people that the stretching, you're doing it in a controlled fashion. In a perfect world, you're actually controlling the amount of force or stretch and kind of limiting it. As Colleen said earlier, this shouldn't be a really painful stretch. It's not a high intensity stretch. I'm going to adjust my camera just a little bit to show you that the muscle fibers themselves are made up of myosin and actin, but the way that a muscle elongates or contracts has to do with the fibers. And so when we sleep and our our foot, we don't sleep with our foot up like this. We all sleep kind of with our feet, whether you're on your stomach or on your back, we sleep in plantar flexion. And what that allows is it allows the Achilles during the night and the muscles above the Achilles to kind of shorten, and those fibers that I was trying to represent with my fingers tighten up. And so as you take a few minutes before you get out of bed in the morning and just work on stretching the tissues in the back of the ankle, your Achilles, but also filling it all the way up into the calf and behind your knee, what you're doing is you're really lengthening the muscle fibers. I describe muscle as the red part of a steak. And if you've ever had a steak and gotten to something that maybe wasn't red and you ended up getting it in your mouth and you're chewing it and trying to spit it out, it's gristle or something else, you can realize that, well, we have that in our body as well. And it's called a musculotendinous junction or fascia, or in the case of a tendon, it's kind of that gristly stuff. And it's very difficult to stretch the Achilles tendon or even really the plantar fascia. What you're stretching is you're trying to stretch through the muscle itself, or the red part of the steak. And that is a very dynamic structure. So if you sit in a chair for a period of time, it tightens back up. And taking a few seconds before you get up and take the first step to loosen that will reduce the pull and help you get over something that may be minor or may be chronic. And so I just really want to kind of emphasize that stretching you're trying to do when you're not weight bearing or when you're not having pain, and the offloading or having a shoe with drop to it or a heel lift, what that does is it just offloads the force when you're walking, so that when you're taking a step with all of your body force, it's not being transmitted directly to the Achilles tendon. So I hope that, I guess, just clarifies. That seems to be one of the questions I get is, gosh, why am I stretching and then offloading at the same time? The other thing with Achilles tendonitis is that when we sleep, we talked about how we sleep in plantar flexion, again, with the ankle down. And so there are some devices that are included in my little slide that are called night splints. And what a night splint does is it helps you stretch essentially while you're sleeping. And I wanted to just show you some examples of night splints so that you've seen them, because they come in different shapes and sizes. Colleen, can you see my screen?
Not yet.
Okay, I must have gotten off of share screen. How about now?
Yep, it's coming up. There you go.
Perfect. Well, let's get back to a full screen.
Perfect.
Page up. What you can see is that all of these devices, which are called night splints, are designed to help bring the ankle up while we're sleeping, and that will help to stretch the muscles. I talk about three different types. The one on the far left is called a posterior night splint. And the posterior night splint is something that's more rigid. It goes on the back of the heel, and it has some little straps that help hold the foot up. And I tell patients the posterior night splint is probably the most effective version. It, however, is so effective that when you're sleeping, you can't get your foot down. And so a lot of times people find themselves uncomfortable, not sleeping well. They say, I go to bed with it on and I wake up in the middle of the night and it's on the floor. What I tell patients is a night splint is really most valuable for the last maybe hour before you get up. So if you've tried a night splint and you just can't sleep in it, it doesn't work for you, I tell patients don't put it on as you go to bed. Set your alarm for half an hour or 45 minutes before you get up. Slip the night splint on, and usually for me, I'm not ready to get up an hour early, and so I can go back to sleep and get a little stretch before I get up, and then before you get out of bed and take the step, take off your night splint and do a little dynamic stretching or active stretching. Colleen, I know you know as a physical therapist the difference between passive stretch and active stretch, but I might take a second and just go over that for our listeners. I'm so used to an interactive environment where I'd ask you, so can somebody tell me what an active stretch is? I want to just say that a passive stretch is when you're using something to pull a muscle. So you put a belt around the ball of your foot and you pull up towards your chin. You're using that belt to pull your ankle up and stretch your calf muscle. That's a passive stretch. An active stretch is where you're using the muscles to pull up. And I'm gonna, hopefully you'll be able to see. I tell patients, I'm gonna use my bicep as an example. So we have a bicep which curls the arm and a tricep that straightens the arm. As physicians and therapists, we think of these as agonists and antagonists. Well, when you fire one muscle, say your bicep, your brain has to relax your tricep in order to allow your arm to bend. Well, it's the same thing in your foot. So if you're pulling up actively, you get reflexive inhibition of the opposite muscles. So those muscles you're trying to stretch. And that's why I tell patients that if you're stretching actively, you're pulling up using a muscle called the tibial anterior, and we'll go over this. I've got some anatomy things I'll show you later. But you actually get a much better stretch than if you're just dropping your heel off of a stair and letting your body weight passively stretch that muscle. Do you have any other, I guess, insight to that, Colleen, with your background?
No, I think that's accurate. I would say there's also some really nice data that supports an eccentric loading type stretch or activity.
Will you explain what that means for people?
Yeah, sure. So how I describe that to folks is the eccentric is when the muscle or the tendon are actually lengthening. So much like Dr. Moore's example of the bicep, when you're curling your arm, that's a concentric, or the muscle is, the ends of the muscle are approaching each other and the muscle is getting shorter. The eccentric would be when that bicep is lengthening. So much the same with the Achilles in this situation. If you were to lower yourself slowly down off of a step, you're actually lengthening that muscle and stretching it sort of at the same time. So it's that long, slow lowering sort of phase.
I'm going to do my bicep again here. You're doing a curl. That curl is the concentric. And
exactly.
The slow letdown of a curl is the eccentric.
Yep, exactly.
And so I think that the example you gave in a toe rise, so if you're working on strengthening your calf muscles, you might be doing toe rises or some work at the gym. That's a concentric exercise. That muscle is contracting and it helps it get stronger. But if you do a toe rise and you slowly let yourself down and you actually go below, so if you're standing on a step and you go up and then you come back down and you go a little bit below, that's that eccentric strengthening that Colleen is talking about.
Exactly.
And for all of the conditions that we're talking today, eccentric strengthening is a great tool to have or to understand as a patient and to employ, again, kind of being aware of pain and not pushing past that. But it's part of our prevention strategy.
For sure. And I would also add to that it's a great way for particularly those that are perhaps doing a lot of hiking or running, where they're doing a lot of uphill and downhill work, essential to strengthen that aspect of kind of unloading the foot as it hits the ground, as in running, or descending down a hill in walking or running. So making sure that that's part of your prevention strategy, I think, is key.
Great. Well, before we leave this slide, I just wanted to, because I have patients who find these, night splints are something that I tell my patients probably the least expensive place to find a night splint is online. And so when people go online, there's 100 different options. And I tell patients that these should not be terribly expensive devices. I looked last night on Amazon and I found, price was all over the board, but I found several good options in the night splint ranging from $15 to $20. So these are not, you shouldn't be spending hundreds of dollars on a night splint. Colleen and I talked in preparation for this about what things they have at FootZone, and the center one is something called a Strasbourg Sock. You can see that it's similar to the other two in that it helps to pull the foot up. And it actually maybe in some ways actually pulls the toes up a little better, which helps to stretch the plantar fascia. I tell patients that a Strasbourg sock is something that thankfully is easy to find. They have them at FootZone, and it's something that tends to be a little more tolerated. People don't mind sleeping them in as much, and I think it's because you can kind of push through it when you're sleeping. If you plantar flex it, it allows you to go down or to push through it a little bit. The Strasbourg sock is something. Strasbourg is a town in France, and I'm not quite sure how it became the Strasbourg sock, but that's the way it's known around the world. So if you walk into FootZone or you look online, you'll be able to find these, and that might be a kind of an easy place to start for most patients. The other option, which is the far right one, is called a dorsal night splint. And a dorsal night splint goes on the front of the ankle, which is very different than the rigid one that goes on the back. And I think the reason people like dorsal night splints maybe a little more than posterior night splints is because it's easier to push through them. And so when you're sleeping, it doesn't maybe do quite as an effective a job of holding you in that stretching position. So I think all three of these are viable options, that you want it to be comfortable and make sure that it's something you can use. And so if you can't tolerate a posterior night splint, a dorsal night splint certainly is better than nothing, or a Strasbourg sock. So I wanted to make sure that you guys at least had the idea of what different things are. So if you go look online, you can be an educated consumer.
Dr. Moore, we have a kind of question about Achilles tendon pain discomfort. Someone who kind of wrote in earlier that mentioned that they've kind of been going through the normal conservative treatment approaches, including physical therapy, taping, and has had this going on for the last 5 minutes and feels like, 5 months. And they plateaued and they still have constant pain and limping. And they're asking for our sort of suggestions. And I thought maybe we'd take this question and then maybe move on to plantar fasciitis.
That's perfect. What I would say is we've talked about the really kind of conservative treatment, which is things that don't require necessarily a physician or a therapist. And so those are stretching and activity modification and good shoe wear and anti-inflammatory, rest. And then I think when it starts to get into a more chronic situation, you've been doing all of those things for weeks or months and it's still affecting you on a daily basis. It's very common for people to get frustrated and look for that next level. So that's usually when I see people in the office and when we initiate physical therapy. And the question, I appreciate, I'll leave names off of it, but I appreciate our listener or viewer who sent in the question, who said in their case they had seen a healthcare professional, they had done some physical therapy, they had done laser therapy, they had tried kinesiotaping, ultrasound, and nothing really seemed to improve things. And so I want to talk about kind of the next level of treatment for Achilles tendonitis or Achilles tendinosis, and those are things that involve external stimuli. So whether it's ultrasound or acupuncture or laser or injections, and I think all of these things are things that for most of our patients or clients at FootZone or friends who are active, probably not necessary to feel like you need to involve some of these, I call it secondary treatment options in the early stages. But when you get to the point where nothing is working, that's where I tell patients that you really kind of need to prioritize getting this better, or it becomes a chronic problem. And I do see patients, I think that FootZone sees patients too who say, I've been dealing with this for 6 months. It gets a little better, I start running again and it comes right back. What do I do? And I think that again, having that broad-based kind of algorithm, which is if there's an activity that really is flaring things up, you got to kind of avoid that or minimize that. Cross-training, stretching regularly, and then as things start to feel better, that's when you start to add that activity back in and starting at a very low level and proceeding up, you always using pain and symptoms as your guide. I also want to talk about some of those other things, laser, acupuncture, ultrasound, electrical stimulation, and then even things like platelet-rich plasma, which is being used in chronic tendon disorders and insertional tendon problems like Achilles tendonitis. And I think that our community, people are educated, people have heard about these things, and they come in and say, should I be doing PRP, or should we try a steroid injection for my Achilles tendonitis? And I want to just pause, because I said a 4-letter word there, and that is steroid injections for Achilles tendonitis are really a bad idea. So if somebody suggests to you that you have a steroid injection, you say, I heard from Dr. Moore and Colleen on our webinar that I shouldn't do that, and that can increase my risk of rupture. And so there are practitioners who may not understand that risk, or who, after 6 months want to do something to try and make you better. And if for some reason somebody suggests a steroid injection into your Achilles tendon, you say, no, thank you.
Run the other way.
Yes, and you will not be getting that advice from Colleen or I. That it is okay to, there's something called Iontophoresis, and Iontophoresis is a therapy term. It's where you use a cortisone cream and ultrasound to try and help drive that cortisone into the soft tissues. And I think Iontophoresis, or topical steroids, or even steroids with ultrasound, are certainly okay. So you don't have to worry that that's going to lead to a rupture. What it can do is just kind of help reduce the inflammation in the soft tissues. Do you have a different take on iontophoresis?
No, I would agree. And I agree with injection. Of course, I would certainly steer someone away from that. I think my only other suggestion to this particular person would be, not knowing exactly what type of therapy they've had. I think it bears to say that we should probably be looking at the joints above and below this area to make sure that those are not really the cause of the overuse. So perhaps it is limited ankle mobility or something within the knee that's driving this overuse syndrome in the Achilles. Additionally, it might be time for that person to take a more significant step in their rest procedure. And maybe that's, really doing nothing, or being in a walking boot, or cast, or those sorts of things.
If simply abstaining or choosing lower impact exercise isn't doing it, and patients are having pain on a daily basis with their steps, then a period of immobilization is very helpful. And that is one of the walking boots that you sometimes will see people around town in. And I tell patients that for Achilles tendonitis, that adding a heel lift in that walking boot can also be helpful. And what it does is, again, it just, as Colleen alluded to, we're taking rest to the next level and actually trying to offload the pull on that Achilles tendon with each stretch. I also sometimes will have patients who come in and say, oh, I had another healthcare provider put me in a boot 2 months ago, and I've been wearing the boot every day for 2 months, and I want to know when I can stop wearing it. And I tell patients that a boot is a good tool in the short run. It can do a great job of offloading the foot and ankle, but walking in a boot for a long period of time can create other problems. I see patients who almost every day who have hip pain or back pain because of an uneven gait, a difference in leg length. And so if for some reason you are in a boot, sometimes having a little lift on your other shoe, there's even a little device called an even up that you can put on so that you're balanced and don't create other problems while you're offloading the Achilles. I'm going to talk about one other thing with Achilles tendonitis / tendinosis. We talked about, and this is again, not that bump down on the bottom of the heel, which in this slide you can see. And as you go up above to this side, you can understand what's causing that bump. It's the bone spur on the back of the heel. You can see there's also a pretty sizable bone spur on the bottom of the heel. And I like this slide because it really, I think it explains why people sometimes have Achilles tendonitis, and some people have plantar fasciitis, and some unlucky folks have both, where it hurts on the bottom of the heel and the back of the heel. So I think the other thing I would say about this x-ray is that just because there's a spur there doesn't mean that it needs to be removed or taken off. And that's one of the things I do find frequently when I have patients who come from podiatrists or other foot specialists, is that they'll be told you need to have the spur removed or your plantar fascia released. And I tell patients that the spur is a symptom just like your pain is, and that if you x-rayed everybody's heel in society, you would have lots of people who don't have heel pain who have a spur. And so I think we hear on basketball highlights when a player's out for a heel spur, we think it's the spur. It's really plantar fasciitis or an overuse injury that the patient's out for. And so I tell my patients that I don't recommend surgical intervention for plantar fasciitis in the form of a heel spur removal. In fact, there's some important nerves and things that are right near that spur that can be injured with that procedure. And so I tell patients that this is largely a non-operative process, a regular stretching, and then at times when it gets to be a more chronic situation and in a higher area up in the ankle, actually doing something to remove the bone spur on the back of the heel or to bring extra blood supply to the Achilles tendon. And that's what this slide is showing, is just that occasionally in a really chronic situation, when you have a big lump and that lump is painful and it doesn't respond to all of the things we've talked about, that doing a little procedure to debride or clean up the tendon or the portions of the tendon that have started to change or to degenerate can trick the body into turning on that healing response and kind of getting past a chronic problem, healing it up and moving on so that people can move back. So I think let's put Achilles tendonitis and that portion to bed, and let's just talk a little bit about plantar fasciitis next, because this is probably the next most common thing we see. Plantar fasciitis is pain on the bottom of the heel. I tell patients that it's most commonly just in front and down in here. But plantar fasciitis, just like Achilles tendonitis, can present in different ways. And so sometimes people feel it further out in the plantar fascia, or even on the outside of the foot over in this area where the plantar fascia is inserting on bones. I don't think most people really understand that the plantar fascia is a dynamic arch support. So what that means is it's kind of like a trampoline. When you take a step, it's like jumping on a trampoline, that the trampoline bounces down and springs back up. And so with the plantar fascia, that dynamic movement, you can understand that there's a fixed point and quite a bit of pull. And so that sharp pain that people feel when they get out of bed in the morning or push off, what's really happening is that on a micro level, there's an injury occurring where the plantar fascia attaches to the bone or originates to the bone. And that can range from soreness to outright pain, feeling that you can't put your heel on the ground. And I tell patients that, again, if you can avoid that pain, you can shorten your course of plantar fasciitis. So again, before getting out of bed in the morning, before you take that first painful step, taking a few seconds, stretching, loosening up the hamstrings, the calf muscles, the muscles in your feet, and then having a shoe that when you take the first step has some arch support and some cushion and maybe even a little heel lift or drop to it, is a great way to kind of address this at home and by yourself. And so I wanted to show you an example, and this is a product that they do have at FootZone. I was going to show the sandal on the right. And I believe that is an Ophos, which is a brand, but the characteristics are far more important than the brand. What you can see is that there is some drop to it, that there is more heel in the back than in the front. I wish I could show you the insole, but there is arch, and this plastic material is soft and molded. So it's almost like you're walking on a pillow. And that's the type of shoe for plantar fasciitis that I recommend, something that's cushioned with a soft heel and that's comfortable for you. And so instead of going barefoot around your house or into the bathroom for that toothbrush in the morning or your shower, having a shoe for that first step can really be helpful. The other things that we talked about for Achilles tendonitis can also be helpful during the night, so night splinting and appropriate shoe wear. And the Hoka brand of shoe has really, I think, changed the way many of us think about shoes. I describe it as a maximal cushion shoe. The other thing that you can see is that there is some drop between the back and the front, but there's also a rocker sole to it. And so as you take a step and roll over, there's a more gradual transition of the force to the foot. Do you have any thoughts on why patients find these shoes so helpful for plantar fasciitis?
Oh boy, I think they've been really well received, and Hoka's done a really nice job, or the shoe companies that Hoka's kind of leading the charge on this maximalist type shoe. I think it's just exactly what you described. They've done a very good job of providing not only cushion, but a stable platform. If you were a person that tried Hoka's when they first came out, I would have to guess that was probably about 10 years ago, but they were much kind of goofier looking. They've kind of brought that cushion down a little bit, so it's not quite so extreme. And now they're doing a very good job with providing some stability within the shoe, as well as that rocker sole that Dr. Morris suggested. So I think just all in all, they've done a really, really good job of providing a lot of things that people need who are on their feet and not necessarily running and walking, but those that are maybe standing on a hard surface working all day. So they've been really well received as just a great all-around comfort shoe for folks that need that support and that cushion.
And I think that's the characteristic of this shoe that is helpful, is the cushion, and I think the stability as well. So one of the things that I frequently see is patients who have had chronic plantar fasciitis and end up seeing a foot specialist, whether it's a podiatrist or somebody else, and they're told that they need an orthotic. And if I tell patients that a rigid orthotic, one that's very hard under the heel, it rarely makes things better. That you want something that's soft and cushioned. And so whether it's just adding a heel pad to your shoe, which both has the cushion but also a lift to it, or choosing a shoe like a Hoka or the Ofo sandal that's shown here that are just very soft and cushioned, that having that pillow with each step is very helpful. I don't want to spend too much time on plantar fasciitis because I think that it's very common, but I also think that patients understand that this kind of comes and goes, and it can, if you've had it once in one foot, it can happen in the other foot, it can come back. And I tell patients that when you first start to feel heel pain, whether it's Achilles or plantar fasciitis, that the sooner you acknowledge what's going on and kind of are aware of what it is, the quicker it is to break that recurrent injury cycle, and the faster you get better. I have had plantar fasciitis almost every summer for the last few years. And I get it once a year when I go on vacation and I'm in a flip-flop for a week or 2 days. And I think that it's a lot of my patients experience that as well. If you've changed shoes, you're spending a lot of time barefoot, you've increased your distance, all of those things can lead to kind of the onset of plantar fasciitis. And if you can catch it early and kind of put out that fire, you can oftentimes, for me, within a few days of coming home from my vacation and wearing a good shoe and really focusing on stretching and kind of choosing exercises that don't flare it up, it's gone. And I think that's one of the things that, if you've had plantar fasciitis for 6 months and experience pain every day, you think it's never going to go away. And I think that just understanding the sooner that you make a change and can stay below that pain threshold, the quicker you'll get that course to shorten. Do you have any other insights from your therapy days?
Nope, other than it sounds like you need to buy a pair of UFOs and take them on vacation.
Yeah.
There is one other quick question that someone else had. about can massage help plantar fasciitis? And I think the answer to that is yes, it can help, along with a variety of other treatments. Most importantly, probably getting the supportive footwear, cushion footwear, perhaps changing the surfaces you're on, avoiding walking barefoot around your home. So wearing the house slipper, house shoe, sometimes an over-the-counter insert is helpful as well, just to add those to your normal shoes, even if it is not an athletic shoe, that gives you a little more support or a little more cushion. We have a variety of those to choose from at the FootZone. So those are all things I would say are very helpful in aiding the plantar fascial problems.
I would agree with that. I was also going to kind of take it to the next step when what to do when plantar fasciitis doesn't go away. And we talked about how with Achilles injuries, we should avoid injections really at all costs. And I wanted to go back to your massage, and these are some good exercises that can be helpful, both plantar fascial stretching and deep tissue massage, whether it's a tennis ball that you're rolling under the plantar fascia. I think many people have tried foam rollers or variety of things for other muscle aches and pains, and there are a multitude of things available. It doesn't have to be fancy. It doesn't have to be a spiky ball. It can be a tennis ball. It can be a can of frozen orange juice. It can be a golf ball. And I sometimes tell patients, if you throw a golf ball in your freezer, the golf ball tends to fit pretty nicely into that little recess back where the tennis ball is on the bottom left over here. And that's where pain usually is. The golf ball also has a little texture to it, and you can vary how much pressure you put on it. I tell patients, you don't want to hurt yourself. It shouldn't be painful, but you should be able to kind of feel that deep tissue massage. And then the ice also helps because it reduces inflammation. So I tell patients absolutely that massage can be helpful. I also wanted to talk about kind of the next level. I'm sorry, my slides are out of order today, but I wanted to talk about another element of treatment for plantar fasciitis that I think is quite common, and it's an injection. And I tell patients that injections for plantar fasciitis can be quite helpful, that they're not fun, that they're painful, but oftentimes that it can kind of give you a push in the right direction. And those injections come really in two forms, either a steroid or something called platelet-rich plasma. And I wanted to there's been a lot of literature and studies out in the last year or two on the difference between platelet-rich plasma and steroids. And I wanted to talk about that briefly today. Steroids have different connotation. We think of steroids in performance enhancing athletes it's a hormone, a cortisol-derivative hormone. But steroids can also be a medicine that's used to help reduce inflammation in the body. And when you do it as an injection, it's a very localized treatment. So it works just where you put it. And so a steroid has an effect of kind of, as I described, putting a wet blanket on the fire. You're trying to reduce the inflammation that's leading to pain. And as that, it tends to be quite temporary. And as it's feeling better, that's a really good time to work on your stretching, to think about your shoe wear, to incorporate an arch support into your shoe to correct underlying deformity that may be contributing to this. And I tell patients that the steroid itself isn't the answer. It just takes away the pain to allow you to kind of do the rehab you need to get over the hump. Platelet-rich plasma it works in a totally different way. I wanted to show you a slide for how it is used. We draw a little blood from an IV site, and then take that blood and spin it in a centrifuge. And as that is spun, the different layers of blood settle out. And on the bottom is red blood cells, or what we call erythrocytes. And these are really kind of thick and solid, and that's not something that we use. There's this little layer in between called the buffy coat, and that has some different types of cells, including platelets and white blood cells. And then this top thin layer, it almost looks like a Pilsner or a golden beer. It's clear, and it's this plasma layer. The plasma has these, cytokines and growth factors that turn on a healing response, and they can help bring extra blood supply and a healing response to tissues. It actually usually increases inflammation in the short run. And so unlike steroid, where we're putting a wet blanket on the fire, with platelet-rich plasma, we're really trying to turn the body's healing response on and help patients get up and over it. And so they work in very different ways. Steroids are something that tend to be quite inexpensive and covered. Your insurance will cover a steroid injection. Platelet-rich plasma, although certainly being shown in the literature to be effective, oftentimes insurance companies share that expense of an injection with patients. And so I always talk to patients individually about what would be best for them based on their individual case or problem. The reason I brought up platelets versus steroid is that in the last year, there have been several papers that look at the efficacy, meaning how effective is this at actually making symptoms go away. And it's really interesting that they're equal. So it really doesn't matter whether it's platelet-rich plasma or steroids. But it is kind of that next level of step. And so I tell patients, I don't start with a steroid injection, but if you've been doing all the right things and it's not getting better, that a steroid injection sometimes is a way of just breaking that repetitive cycle of micro-injury, partial healing, re-injury, and then starting the cycle all over again, which is really how I think of plantar fasciitis. You think that kind of covers things okay?
Yeah.
I would tell patients that occasionally, I tell patients that Achilles tendonitis and plantar fasciitis are usually non-surgical problems, but occasionally in very rare cases, surgery is necessary, and be happy to talk with patients if it ever gets to that point about kind of options for surgical options. I wanted to maybe move past Achilles tendonitis. Have you gotten any other input from folks on things that?
We do have a couple of questions about repetitive ankle injuries and sort of how to recover from that and the pain level kind of following that.
Let's talk about one other thing that I think is fairly relevant to where we are now, and it's alignment of the foot and ankle. And so Colleen earlier, when we were talking about Achilles tendonitis and shoe wear, she was really smart to say you really want to individualize that to the patient. If they have a knee problem or an ankle problem that doesn't allow them to bend, you need to address that as well as the things that we talked about. And so plantar fasciitis and Achilles tendonitis tend to be more common in patients who are pronators. And a pronator means that the arch of the foot is collapsing. And so you can see in the slide with the blue line that is all lined up, this is a neutral heel. And on the left-hand side is pronation. And then the far left really shows an extreme example of pronation. And we call this the too many toes sign. If you're looking from the back, it seems like, my goodness, they must have 7 toes over there, because you can see 4 of them out here on the side, or 3 of them here, where over here you see 1. And it just has to do with the collapse or the pronation of the foot that's occurring. And so pronation is, well, deformity in the foot, whether it's pronation or supination, certainly is one of those underlying risk factors for things like plantar fasciitis, Achilles tendonitis, and many of the other things in the foot and ankle that cause pain. And I wanted to just talk briefly about something called tibial tendonitis. And I'm going to use this slide. The tibial tendon is the one that supports the arch of your foot. It's also what you use to go up on your toes. And so whether it's with overuse, hiking, running, biking, or from deformity, this tendon can see a lot of force and also stretch out and become painful. And so the red is just for the purpose of the slide to show you the distribution of the pain. And you can imagine they're showing this patient standing with an arch support to try and support the arch from the undersurface and not allow it to collapse. And what that does is it offloads the tibial tendon. And I wanted to talk about this because people who are pronators, if that's part of the reason that Colleen talked a little bit about shoe wear, of different types of shoes. We talked about shoes that have drop or lift, a heel to them. but there are also shoes that have different characteristics of the sole. And particularly, I call them a stability shoe or a pronation control shoe, helps prevent the foot from rolling in. Colleen, do you have an example of a pronation control shoe?
I do. I have a couple of options. We have kind of shoes have gone through a little bit of an evolution where if you're looking on the inside of a shoe, like this one, you'll have something called the posting, which is sort of these different colored type of foams and EVAs and plastics that help to decrease that risk for the foot collapsing inward or the arch collapsing inward. A variety of shoe manufacturers have kind of changed how they look at some of this, and there are still anti-pronation shoes. One of the kind of more common things we're seeing now, though, is what one particular manufacturer is doing is kind of what they're calling a guide rail system. So they're saying, we're going to not super control your foot because we want it to have some natural movement. We don't want it to collapse, but we don't want to over control it. So this particular shoe has what it calls guide rails. And so there's a kind of a support system here on the outside as well as on the inside. So it kind of just keeps your foot kind of on the rail and on that platform of the shoe. So most of the shoes you can kind of look at, what's in the heel, kind of here with a different kind of level of plastic foam, and what the different colors are. And you can see that there is more buildup, more anti-pronation, more control to the shoe.
And this is a great time to highlight the knowledgeable salespeople at FootZone who can tell you, hey, you're rolling in. You guys have a treadmill and a camera where you analyze gait and can kind of show patients what you're seeing and then direct them to shoes. I tell patients that a pronation control shoe generally has a sole that's a little stiffer on the inside to prevent you from rolling in, and a little softer on the outside. So it's good for somebody who is pronating or rolling in. But if you're a supinator and have a tendency to roll out, it actually may worsen your problem. So, reaching out and asking somebody to help you with your shoe purchase will actually save you a lot of time and heartache in the long run. I tell patients, don't buy a shoe online until you've tried it on and you know that it's the right shoe for you. And I would never buy a shoe without putting it on my foot. So go talk with Colleen and our FootZone colleagues before buying something.
Yeah, we also have a foot scanner, which is something that's relatively new to the FootZone. Which is also really helpful for the patients to, you step on a platform and it shows sort of how high or low your arch is, and it gives you an actual visual representation of your feet. So like Dr. Moore showed on a previous slide, you could see how that Achilles lined up vertically or sort of had an angle to it. Our scanner will show you that, and you can see from the rear view of your foot of what that might look like. So it gives you a nice appreciation of what your feet are actually doing as you stand and walk.
Well, and I think that this is a good time. One of the other things I wanted to do with you, Colleen, was just talk a little bit about arch supports, because I think that they come in all different shapes and sizes, from things at Walmart where you go stand on a machine and Dr. Scholl spits you out an A, B, or C, to over-the-counter arch supports that are really not made for any one foot, but have characteristics that are helpful for many different characteristics. So I always think of Superfeet as a good one. You mentioned another brand that you guys have had really good luck with.
Yeah.
And I tell patients that an over-the-counter arch support is a great place to start if you're noticing arch pain, or that if you get out of the shower and you're noticing your footprint is a little more pancake-like than it was before. You had some toes and a heel and your arch never touched the floor, and now you're seeing an arch support might be a really good thing for you. And arch supports come in very different price points as well. And so I tell patients that an over-the-counter arch support, like they have at FootZone, is a great place to start. They're usually in the kind of $35 to $50 range, as opposed to a custom orthotic that can run several $100s. And so I always think that if it were me, I would start with an over-the-counter arch support. And worst case scenario, if it didn't work, I wouldn't feel like I wasted a lot of money if I needed to go to a custom orthotic. The other thing that I tell patients about arch support, and I think it's paramount, is it should be comfortable. So if you put something in your shoe and it doesn't feel good, I would not leave it in your shoe and walk around for 8 hours, because at the end of the day, you're going to have a very sore foot or a back problem or something else. Orthotics directly change how your foot makes contact with the floor, and those forces are shifted to your knees and your hips and your back. And so when you are trying a new shoe or a new orthotic, it's a good idea to, I say, break them in slowly. You don't want to put it in and go for a 12-hour shift on your feet. You'll come home an unhappy camper. The other thing that I tell patients is that new orthotics and new shoes can actually sometimes cause injury. I've had patients who say, oh, I got this new pair of work boots, and boy, they're the best ones made, and then I wore them for a week, and now I have pain in my foot with every step. And so I've seen stress fractures and other things from simply just changing shoes. And so I like how earlier on you said rotating shoes is a good idea. And if you're trying a new shoe, or certainly a new style of shoe, if you're going to a maximalist shoe from a standard shoe, break it in slowly, be patient, listen to your body and those cues if it's working for you. So tendonitis, I think we've talked about several of the major ones: Achilles tendonitis, plantar fasciitis, posterior tibial tendonitis. I want to just mention also something that kind of, if you're noticing changes in your foot, and the things that we've been talking about today are things you've been dealing with for years, you may also be progressing past the point of just an acute inflammation problem and more to something like posterior tibial tendon dysfunction. And this is where it's a really, I think it's helpful to see a specialist and get an x-ray of your foot. Am I sharing my screen right now with, let's try that. Is it showing on there?
Yep.
Great. So if you can compare this with the previous or pictures of the feet that I've shown, and you can really see that the arch of this foot is collapsed. And the tendon, the posterior tibial tendon that supports the arch of the foot, that's circled in red, is boggy and swollen, and it's stretched out. I describe this almost like a hammock that's dragging on the grass, and you need to go over and tighten the chain on the tree and cinch that hammock back up. This is a foot that is breaking down and probably needs more than just a over-the-counter orthotic. That as this foot pronates or rolls with each step, you can see how the posterior tibial tendon, both circled in red and with arrows on it, just gets stretched to beat the band. And so this is one where really controlling that deformity is going to be very important to getting pain to go away. And so I think that in this situation, a custom orthotic or potentially even surgical intervention can be necessary. So we're not talking about surgery. We're trying to keep you out on the trail and running. So I just wanted to kind of mention that like all things, these things kind of go on a scale from mild to moderate to severe to sometimes even needing surgery. So do you think, Colleen, it's good to just go in our last few minutes here and talk about ankle injuries and recurrent sprains and impingement a little bit?
Yeah, I think that'd be a great way to kind of finish things up.
And then I do just want, I know it's been a long evening. Thank you for sticking with us. The foot is, for me, is exciting. For patients out there, it's essential for getting around. And so if there's something that we didn't cover tonight in the last minute that you want to shoot Colleen email question, I'd be happy to turn it over and field those questions and use the last bit of our time for that. While we're doing, am I still sharing screen?
Yep.
Okay, good. Well, I'm going to just go down to ankle injuries, and in particular, let's talk about ankle sprains, which is perhaps the most common injury that I see, and one of the most common sports-related or activity-related injuries. The most common form is what we call an inversion injury, or a roll of the ankle. It's the most common injury in all of sports, and I think many people have had one. I think most ankle sprains do resolve, but there are characteristics and things that don't. And that if you're unable to put weight on your ankle after a bad ankle injury, you really need to get an x-ray. And that's one of those take-home points from tonight, that if you roll your ankle and you're able to put weight on it, and there's not a lot of swelling, the guideline is that it's okay to kind of follow that and see how it's going, unless you have deformity or point tenderness to palpation that makes you think you broke your ankle. But in a mild ankle sprain, not an x-ray isn't always needed. And we talk about the Ottawa criteria for ankle sprains. The Ottawa ankle rules really define when an x-ray is needed. And I just tell patients that bony tenderness over the bumps on your ankle, which we call malleoli, either your medial or lateral malleoli, if it hurts to push on the bone, you need an x-ray. If you can't put weight on your foot, or you have pain over the base of the fifth metatarsal, which is a little bone on the outside of the foot below the ankle. So if you're hurting down in here, that's another time where an x-ray is important. And I just want to highlight that at the center, I know that with COVID and changes, that sometimes it's hard to get in to see a physician or get an appointment. And we have tried to really address that with Now Care. We call it Now Care because we want you to know that you can come in and be seen by a specialist without an appointment in a situation. You roll your ankle, you can't put weight on it, you need an x-ray. Please come see us instead of going to urgent care or to somebody who isn't used to dealing with this. They'll get an x-ray and then send you to me for an appointment. Whereas at the center, we'll get you in and try and make it as easy and quick for you without a long wait in the ER, and get an x-ray if we need to, or maybe not do that if we don't. So I just wanted to highlight that service and let you know that it's available. So we're here for you. I think that the Ottawa rules were really designed for physicians because people x-rayed every ankle injury that came in. And what we realized is that if you don't have bony tenderness, if you're able to weight bear, that a lot of times an x-ray really doesn't change the way we manage things. So I tell patients that ankle sprains come in mild, moderate, or severe forms, that mild ankle sprains are a stretching of the ligament. The ligaments that are injured are almost always these ones on the outside, the anterior talofibular ligament and calcaneofibular ligament. Grade 1 means that they're stretched, grade 2 means that they're partially torn, and grade 3 means they're completely torn. And oftentimes grade 3 injuries actually come all the way around the ankle and involve the inside or the medial ligaments as well. And I just tell patients that the grade of injury is important because it helps you know how long it's going to take until I'm going to be better or back to doing my sport, walking or cycling or different things. And in grade 1 injuries, these sometimes get better in a couple weeks, 4 to 6 weeks. Grade 2 injuries, sometimes 6 to 8. High ankle sprains, which are a little different character, and we can interest, but I tell patients high ankle sprains sometimes take 3 or 4 months, and grade 3 ankle sprains, when you've completely torn the ligaments, those have risk of long-term problems or recurrent ankle sprains or instability. And that's really what we're trying to prevent in treating ankle sprains, is to allow those ligaments to heal and tighten back up so that you have a check rein or something to prevent you from rolling when you step on a pine cone or a crack in the sidewalk. I want to just briefly mention that, again, kind of the simple things: rest, ice, elevation, anti-inflammatory medication, compression. Those are great ways to start. I think that in high ankle sprains and grade 3 ankle sprains, those injuries are more severe, and you know it. And usually people are coming in for evaluation and an x-ray. I tell patients that if you have an unstable ankle or grade 3 ankle sprain, thankfully, those ligaments can still heal, and you can prevent instability by treating it appropriately. In those grade 3 or higher energy injuries, sometimes a walking boot is needed, or even a cast to really maintain the position of the ankle while those ligaments are healing. And so I don't routinely get an MRI to look at the extent of tearing. I base that more on clinical picture, and the timeline that I mentioned before. Each sprain should kind of be getting better according to its own timeline. And so when patients are 6 weeks out with a mild ankle sprain and still having a little pain and swelling, I tell them it's okay, I expect that. If you're 3 months out from a mild ankle sprain and still hurting with every step, something's going on. That's not a normal course. And so that's when I would suggest coming in for evaluation or even further imaging with an MRI. I think that in all, and I'd love your perspective as a therapist, Colleen, but in all ankle sprains, the number one goal is prevention of another injury. And in my mind, I see that first ankle sprain followed by a second ankle sprain or a recurrent injury fairly frequently. And I think it's because patients are sore, their brain and their ankle aren't working perfectly coordinated. I call that proprioception, but proprioception isn't always there. And then also there's sometimes weakness associated with the injury and pain, and so you can't correct or prevent the sprain. And I've actually seen where the second or even third injury is sometimes worse than the original injury. So I tell patients prevention in that early post-injury period is really the key. And one of the simplest ways that I say to know when things are getting better enough that you can start thinking about returning to sports or more aggressive activity. And this is kind of lick your thumb and put it up in the air to see which way the wind is blowing. But when you can hop on one foot, and obviously if you can't hop on one foot before, don't try it after an ankle injury. But that ability to, on an uneven ground, whether it's grass or gravel or if you can hop on your ankle, 5 or 10 times with confidence, it's probably time for you've recovered enough that it's okay to start trying the things that you want to do. If you are uncomfortable hopping on that ankle, the connection with your brain, your strength, your proprioception, they're not there, and your risk of another injury is higher. So I tell patients that avoiding those higher demand activities, uneven ground, sand trap at a golf course, or stepping off of a lip, you want to really be careful because you can set things back. And I think that whether it's a boot or an ankle brace or an ankle sleeve or an A-strap, some form of compression and stability can really help prevent that in those early stages. The other thing that I think has been really shown to help is post-injury rehabilitation. So things that when I see people in the office, I give them a handout of some home exercises, including balance and strengthening exercises to help you get back. And so both of these people are working in different ways. The guy who's standing on the top in the star is doing, I call it a tippy bird, and it's a tricky exercise that really requires a lot of strength and coordination in your ankle. And I think that physical therapy has been shown to both improve and shorten rehab time after more serious ankle injuries. So we can help get you in with some help in the recovery. High ankle sprains are usually a little higher energy, and I think that they're more rare, and I'm going to kind of skip that in the hopes of just kind of talking about the sequela of ankle injuries and what we really want to avoid, which is ankle instability. And ankle instability means that those ligaments aren't doing their job anymore, and the ankle's rolling when it shouldn't. So this isn't, coming down on another basketball player's foot and rolling. This is the type of thing where patients roll their ankle stepping on a juniper berry on a sidewalk, or a small difference between carpet and a hardwood floor or something causes a roll. And oftentimes in ankle instability, patients just describe their ankle as being loose. I've got a loose ankle. And oh, what do you mean by loose ankle? Oh, I can roll it and it doesn't really even hurt anymore. what I tell patients is that ankle instability or recurrent ankle sprains, they catch up with you. Just like an injury in high school football sometimes leads to a problem that causes a knee replacement as we're in our middle age. Recurrent ankle sprains cause damage to the joint and to the cartilage in the joint. And so post-traumatic arthritis or arthritis of the ankle because of recurrent ankle sprains is completely preventable. And so I tell patients that if you have a bad ankle sprain, taking care of it, getting it to heal appropriately, preventing that recurrent injury, and then if you are having ankle instability or recurrent injuries, that preventing them either with bracing or therapy, or even a surgery to tighten those ligaments back up to prevent ankle sprains will pay dividends in the long run. So it's all about prevention.
Dr. Moore, I think we should probably wrap things up and send things back over to Jamie.
That sounds good. Well, thank you, Colleen, for spending your evening with us.
Likewise.
Thank you for organizing our webinar tonight, and thanks to all our viewers who tuned in and stayed with us for our discussion.
Yeah, thank you, everybody. I want to make a quick mention. FootZone has generously given everyone a $10 coupon, which I will include in a follow-up email tomorrow afternoon. And so keep an eye out for that follow-up email. You'll see a link to click on that, and you can print out the $10 coupon to take into FootZone to spend however you like. And then we are also going to raffle off a $25 gift card to a lucky attendee. So we'll be doing that drawing this evening, and I will announce that in the follow-up email as well. And then we'll get that over to you as soon as we can. So I think that is it to wrap it up. Thank you again, Colleen and FootZone, for joining us. Dr. Moore, thank you very much.
You bet.
And everyone, we'll see you on the next one. Thanks for joining us.
Good night.
Since inception, our mission has been to make a difference in the lives of our fellow Central Oregonians through exceptional care and compassion. Our team of highly trained orthopedic, neurosurgery, and physiatry doctors offer a wide range of treatment options to restore the health of our diverse patients. A community as expansive and varied as the Central Oregon landscape itself. We treat our patients with compassion because we understand how important their passions are to them, be it working outside, getting out on the water, or a walk in the woods. We do what we do because it's all of us thriving together that makes our home in the high desert special. The Center. Whatever your passion, find your strength here.